Hello everyone. Today's topic of discussion is cystourethrogram, which is also known as the moving picture of bladder and urethra. It is actually a dynamic fluoroscopic study that captures the urinary tract in action. Means when the urinary tract is voiding or when it is filling, then what type of activity it actually do. That is totally revealed by this cystourethrogram. So for that reason, it is termed as the moving picture of bladder and urethra. In few lines, we will understand what it actually does in one breath. Contrast is injected into the bladder to visualize the bladder, ureter and urethra. So this is very important to note down that three very important parts of the urinary system are highlighted in cystourethrogram. Number one is urinary bladder, number two is ureters, and number three is urethra. So detecting structural as well as functional abnormalities that other modalities miss. So this is the importance of the cystourethrogram to know about the functional and the structural abnormalities of these three structure of the urinary system: bladder, ureter and urethra. So these are the conditions in which this has been done. Number one is cystitis, means the bladder wall inflammation and irregularity, obstruction, if there is any blockage in the urine flow. Number three is bladder calculi, if the stones are visible under the fluoroscopy. Then vesico-uretral reflux, retrograde urine flow into the ureter, means rather than coming out from the body, it is again going back to the body. So which problem actually it solves? Voiding cystourethropography, which is also known as VCUG or MCUG, it is a dynamic test that evaluates the urinary tract while it is voiding during both filling and voiding phases. Means when it is in resting condition, not in that pose, when it is actually filling and it actually squeezing out the liquid inside, that is the point where it works. Unlike static imaging, VCUG captures real-time function, making it the gold standard for assessing the urinary retention and vesico-uretral reflex in a single study. So, when the urinary bladder is not under function, then it gives a static functional image. But in case of VCUG or voiding cystourethropography, we can see the movement of the urinary bladder and how it evacuates and how it is filling, how it voiding. Everything is totally visible, which gives us a more clear picture. So why this reflux is a plot twist. VUR or vesico-uretral reflux is the most critical finding VCUG is designed to detect, and its consequences can be severe when missed, especially in the children. So now we can see the difference when the VUR is undiagnosed, means this vesico-uretral reflux, when it is undiagnosed, what can happen? It can do the renal scarring, then there will be silent kidney damage and there will be recurrent pyelonephritis, so which will ultimately cause the potential renal failure. So this VUR should be detected, and in the right part we can see that what happens to the kidney when the VUR is diagnosed via VCUG. We can do the timely intervention, we can apply the antibiotic prophylaxis, and even there is a surgical options also, and which will ultimately preserve the renal function. So this is the difference. If a kidney is suffering from VUR, we have to do the VCUG so that we can retain the proper kidney function in the children. The real world stakes when VCUG is considered. When we will do the VCUG? There are five important situations where this can be done. Number one is febrile or recurrent UTI. If a person is or children is suffering recurrent UTI, means urinary infection with fever, then VCUG can be done. If there is a problem of hydronephrosis, that means dilation of the kidney or the ureter seen on the prenatal or postnatal ultrasound, if there is hydronephrosis, then this can be done. Hematuria, if blood appears in the urine, that can also be detected by VCUG. Then voiding dysfunction, abnormal voiding pattern, etc. also can be determined. Congenital anomalies, if there is any congenital anomalies or syndromic condition or spinal abnormalities, that can also be detected by VCUG. So these five are the most important problems which can be identified well in VCUG of children. How the test feels on the imaging floor. So what are the steps? Number one is sterile catheterization. That means a catheterization of the bladder is done with the minimum infection. So the total environment will be sterile. Number two, contrast infusion. Radiopaque contrast is slowly infused to fill the bladder under fluoroscopic guidance, which will guide us to know that how the bladder works when it is filled. Filling phase imaging. Number three, spot images captured as the bladder fills, assessing contour and capacity. Whether the filling is appropriate, whether it is containing the total amount, etc. These all can be seen by the filling phase imaging. Likewise, voiding phase imaging is also there. Dynamic radiographs obtained while the patient void the critical diagnostic window. So these are the four steps of VCUG. We have to we have to do sterile catheterization, then contrast will be infused, then the filling phase will be imagined and the voiding phase will be imagined. So what are the positions in which we will catheterize or we will do the urethrogram? So for the male patient, there is right posterior oblique. For the female patient, it's anterior posterior projector. So these are the parts which is different for male and the female patient to give the clear view of the kidneys, included its efflux or the hydronephrosis if suspected. The during voiding moment, which is very important, where the total answer lies. Radiographs captured during active voiding reveal efflux and lower tract abnormalities that may only manifest at specific phases of emptying. It can detect the reflux, then urethral anatomy if it is totally means anatomically there is any problem, then bladder dynamics, whether the bladder is working properly. Reading the signs, whatever the sign we can see, we can grade it from grade 1 2 3 4 5. Now this grade 1 up to grade 2, this 1 and 2, where in grade 1 we can see a reflux into the distal ureter only. In grade 2 we can see reflux reaches the renal pelvis but there is no dilatation. These two part can be reversed with the help of the antibiotic prophylaxis. You can see prophylactic antibodies, but beyond that, that is the grade 3 4 and 5, that indicates that the problem is very serious and that might undergo surgical intervention or urethral recomplantation and etc. What is the clinical payoff? Cystourethrogram and VCUG deliver what no static scan can. And what is that? Functional and dynamic anatomy of the urinary bladder and urethra in real time. What it confirms or rule out the VUR. Definitive diagnosis deliver targeted treatment pathway. That means in which way the treatment can be done. whether it will, in which grade the problem now persisting. In grade 1 and 2, that can be totally uh, means helped out with the help of the antibiotic prophylaxis. Then guided management decisions, that how the treatment can be done, in which grade the problem is lying, protect the renal function. Both of this ultimately protect the normal renal function, both in the case of the children and in the case of the adult also. So thank you for listening. Please like, share and subscribe my channel eduhub.2m, where I used to bring new videos, and please subscribe my channel so that the notification goes to you in time. Thank you very much for watching. So long. Bye bye.